The next section is on time already, so I would like to invite attendees to come to the room, and we, in order to start the section. So, on behalf of the faculty of the section, I would like to introduce Dr. Rosli and Dr. Takashi, Dr. Dak, and then, enough faculty already, so we start. So I would like to invite first speaker for this section. It talk about the topic entitled Distal Radial Approach in Complex PCI, presented by Dr. Fauzi, my friend. Fauzi, please.
Thank you very much for inviting me. It's a great honor for me to be here in Vietnam, in Saigon City. I was here 7 years ago, and very unforgettable moments. So today I'm assigned to talk about distal radial approach in complex PCI. Distal radial is the facial access, is the smallest facial access nowadays, but to perform the complex PCI, how we deal with this. I have no conflict of interest. Dealing with the complex PCI, most of the time you need a large bore guiding catheter. So this is the requirement if you are dealing, especially with very high complex PCI. Excuse me. Of course, you can do using a 6 French guiding catheter with such a complex case, but you cannot do implantation of 2 stents at the same time. And then if we are using a rotational atherectomy more than 175 millimeter or bailout strategy, you need a large bar. And in complex PCI, all strategies are on the table. A large guiding catheter give a good support and enough space to accommodate multiple devices and other operations, including if you are dealing with the CTO. The problem if you are using a large bore, we are willing to switch the access to femoral, but the femoral is a high bleed risk. The study demonstrated in these measures at the GM cold cardiology interventions demonstrated if you are using a radial approach, proximal radial approach, it is less bleed compared with the guiding catheter, with the transfemoral. Even the mortality is less if you are using a radial approach compared to the femoral approach. But the right radial artery is not always available for access. Sometimes you are willing to use a right radial artery, arthritis of the elbow, shoulder joint, who are unable to supinate, the risk of optimal access or radial artery occlusion and tortuous vessel. You are unable to use this right radial. And you are willing to use a left proximal radial access, you have to bend over the patient and high radiation. And this is if you are dealing with a complex coronary intervention, it's going to take long durations. That's why it is uncomfortable for the patient and the operator. In 2017, Ferdinand Kimenich learned from Iran operator to use distal radial, and then the Iran operator, Dr. Rogani, learned from Russian operator to use left distal radial, and he demonstrated the study of intervention using left distal radial at that time in 2007 and spread over the social medias. And this is the radial artery anatomy. The Palmer said the radial artery descends along the lateral aspect of the radius, and then if you are feeling at the flexor carpi radial and the anterior of the radius, you can palpate the radial artery. And then the radial artery goes curling to posterolaterally and past the side of the dorsal side of the wrist, and then you can have the distal radial. And the puncture site is the two sides, which is an anatomical snuff box in the intermetacarpal space. Please raise your hand and then extend your thumbs. And you are feeling the depressions, triangular depressions. And then this is space, and this is the snuff box. Yes, you're here. Yes, yeah, here. Yeah. So what is the advantage of using a distal radial access? Of course, you have a similar advantage of proxy radial access plus favorable ergonomic favor complications and another non-femoral option for access and rapid hemostasis. And this is left distal radial access that we did in our hospital, which is a natural walking position for the operator. Even my fellow doing distal radial is very comfortable. But the constraint of distal radial access, there is some constraint, longer access time if you are not familiar with, length of catheter for tall patients and the paucity of data. And the other one is small vessels. Distal radial access is smaller than the proximal radial access. So how to use a distal radial access for complex PCI? You are too small to challenge me. And the diameter of the distal radial access, if you try to find out for this literature, there is a varied greatly in various studies. And this is the largest distal radial diameter is found in Japan study, use about 3 millimeter diameter. And distal radial access is about 0.8 ratio compared with the forearm radial artery. In this Korean study, distal radial diameter, the predictor of the small distal radial is a female sex, low BSA and low BMI. In this particular situation, we have to use ultrasound to detect whether we can use the distal radial access to insert the large bore of the guiding catheter. And vascular ultrasonographic finding of radial artery, interesting that it can enlarge. It's 9 millimeter to 16 millimeter, 9% to 16% of the artery enlarged. Percent. Then that's why if you are using the distal radial and then the next after you are measure the radial artery, distal radial artery, it enlarged. And this is a feasibility and safety of left distal radial approach percutaneous coronary bifurcations showed a success rate with distal radials 100% and access crossover of the bifurcation 0%. But this is using most of the time using 6 French. Is it possible to use 7% 7 French guiding catheter? Large bore sheath in distal radial artery, if you are using a standard 7 French sheath in distal radial, we cause significant sheath radial artery mismatch, resulting in low puncture success rate, pain, radial artery occlusion, and other complications. So a thin wall sheath, which outer diameter were comparable to that conventional 6 French sheath, could facilitate successful complex PCI via distal radial access. This is the study conducted by Dr. Gasparini, which study using a distal radial access 7 French using a glide seat slender in 41 consecutive CTO PCI. And then it concluded that the LD3 left distal transradial access in CTO using 7 French glide seat slender is feasible and safe with high procedural success rate and low access rate complications. And this is the study from China demonstrated using the 7 French thin wall sheath via distal transradial access, which is showed that the high puncture success rate, high procedural success rate, and low post-operative radial artery occlusion rate, and low incidence of local hematoma and other complications. So this is the illustrative of complex coronary procedure that we did. First case is we are using this 64 years old male stage PCI to calcified distal left main. Then the IFUS demonstrated a very tight stenosis here and very small minimal lumen area which are severe stenosis. And at that point, based on this IFUS finding, we use a 2 millimeter burr to radial artery, and then after burring, we use a balloon dilatation until 3.5, and it showed that the crack, and then afterward, we putting the stent. Oh, sorry. Which demonstrated a very good result. So this is using a slender sheet from the thermo. So this is the case 2 clinical data. This is 55 years old male and active police general. BMI 31, CVRF diabetes mellitus. He complained of chest pain, and he diagnosed as unstable angina with LVEF 30%. And MRI demonstrated viable all territory, possible new injury infarction at the circumflex territory. And look at this is the CTO RCA. And this is the CTO of the LAD. And so we stage a complete revascularization of a first PCI to LAD CTO, anti-grade approach, access dual access, using radial distal, right radial distal transradial access, using 7 French, and left distal radial using 6 French IL 0.75 and IFUS assessment. So we successfully crossed the CTO, and then we use IFUS evaluation. We demonstrated huge plaque burden involving ostial LAD to left main. So we have to perform left main LAD stenting, but after stenting to LAD, distal mid LAD, we dilate the circumflex using a balloon, and then putting the synergy to LAD left main, and then end up with the POT. So final angiography demonstrated how we use both of distal radial access in CTO. And the next, we are using again the distal radial artery in 6 weeks, and still we can use it. And then we treat the RCA. We use a hybrid DES and DCB. The third case is presented, this is with stable angina pectoris, CVRF hypertension, referred to our hospital for left main bifurcation, refuse KBH, syntax score 29, normal AEF, normal alpha patients. And this is the case. So we use a distal radial, transradial, right transradial artery, guiding catheter EBU 3.7 French, and provisional left main PCI OCT guided, and we use MCS to IBP. And this is the OCT show. There is lucky there is no calcifications. And then we are prepare the lesions and afterward we are using a DCB at the circumflex and crossover left main to LED using 3.5 38 millimeter resolvers and POT, and rewiring to circumflex using crusade guiding catheter. Then 3D OCT run after left main crossover stenting, but you see that is the wire goes to the proximal part, and this is the link connecting here. So we have to rewire, goes to the optimal strut. And then after reroute the wire to optimal strut, we are finally using skin balloon inflation. And this is the OCT result, no gel start preserving while preserving the stent geometry. This is the study, then this is the result. The last case is a male, 53 years old. He has planned for stage PCI to left coronary artery, left main, prior PCI to another hospital. And echocardiography demonstrated EF 41%. And this is we use SIF from France, and we're dealing with the problem with this guy. When we are delivering the OCT, there is a dissected at the ostial part of the circumflex. So what happened is so rail of our OCT catheter knocked proximal left circumflex and dissection at corresponding segment. Luckily, we are using the 7 French guiding catheter. Patient experienced for chest pain and then dissection proximal circumflex with reduced antegrade flow. And then we end up with the, I think I have to move forward. We end up with the left main decay culotte stenting. This is the result of the decay culotte with 3D OCT evaluation, no gel strut in the circumflex artery. And this is patient hemodynamic was stabilized, ECG normalizations. So distal radial access is feasible in complex PCI, which require large guiding catheter. Is an introduction of thin wall stitch to facilitate the successful complex transradial artery procedures. The distal radial access is no more important than safety. Patient on the table who undergoing complex PCI. So don't die for distal radial access, but the most important part, the safety patient on the table. And more data is required in a randomized controlled trial to fully evaluate the advantage of distal radial access in complex PCI. So size doesn't matter. Thank you very much.
I think we'll take some questions because it's a different topic from the others. Anyone who wants to ask any questions? Or any experience? Yes.
So, nice. Thank you for a nice lecture.
Thank you.
So, when you do puncture for this distal radial artery, do you use ultrasound or do you just feel and puncture?
Yes, most of the time we are not using ultrasound. But if we are willing to perform in the women with small women, and then we are using ultrasound.
I see.
To make sure that the distal radial is quite big if you are dealing with the want to insert the guiding.
Yeah, I think that's an important point. Most of the cases you presented today, that was all the male patient, but sometimes the small old ladies, we need to check the size of the distal radial.
I think so. Yeah, right.
Thank you.
Yeah.
So just short question that you think that you use distal radial artery in order to like a surf. Keep that for the next BCI, or because the proximal, the traditional radial artery is very easy to poke. So why do you have to move to the distal one?
I'm doing the distal radial is faster than proximal one, because in the proximal one it is a line. In distal radial, this is pinpoint. You can just hit it. So. That's why if with my fellow sometimes they use a fail to proximal part, and then we are just doing the distal radial. So becoming familiar with the distal radial becoming more easier than the proximal part.
Which is easier, anatomical stump box or the web? Because I find that the web is so much easier to.
Whatever. You can do both. Yeah. What important is how the learning curve. Yeah, the learning curve, because if we are not willing to switch to the femoral artery, we have to learn the distal radial.
Anyone else? Yeah.
Thank you for your presentation. And the Asian patient is small.
Yes.
So I want you share your appearance to show the patient which one you chose for distal, which one you chose for proximal.
Yeah, but sometimes if you look lady, small stature, but sometimes it's very big distal radial. But other part is demonstrated by study by Dr. Kim that this is a indicator for the less than 2.3 millimeter diameter. And at that time we are using ultrasound. Yeah. Yeah, ultrasound is already in on our side, so yeah, we're using it.
Okay, Fauzi, I think we'll have to let you go first. Thank you very
Thank
much,
you very much, yeah.
for exciting work. I will probably have to do a bit more distal radial myself. Okay, Dr. Hung, my co-chair, will present on aorto-ostial coronary CTOs. Can we revascularize them by PCI when surgeons refuse?
Yeah, thank you very much for the introduction. Good morning, good afternoon, everyone. So nowadays, a lot of doctors, they do the structure intervention. So, but before that, the surgeon, they replace the valve. So, but once they resend the patient to us, so we have to do something because they deny to redo the CABG for the patient. So I had here the one patient to share with you that the patient is 72 years old gentleman. He just spent for 1 year, but he had a history of mitral and aortic replacement, valve replacement for at least 8 years already. So cardiovascular risk factors, ex-smoker and dyslipidemia and past medical history. As I told you that the very long history of the mitral and aortic replacement. But recently, 1 year, the patient had chest pain. And he still feel okay, but the pain is actually not very typical. So it lasts for 1 year and come back to the hospital. EKG showed that the AFib and QA at V1, 2, 3, and V4, and inverted T-way. And this is the echo and chest X-ray. You can see that the two valve and on chest X-ray and hypokinesia at the anterior wall of the septum, and this is the angio. Okay, so this is the angio for the right coronary artery. What do you see? This is the two double valve, and you see nothing on the left side, just the right side and the angio. Only the right coronary give the whole cholesterol to the left side, and we couldn't get into the left main because the left main disappeared already. Nothing more up there. So we did the angiography with 6 friends, 3 transradial, 7 friends for the femoral, another 2 cup with us. And we use at first we use the AL side horn 0.75, 85 centimeter, and the dual injection again, and make sure that the left main disappear, because before that you are not convinced that the left main disappear actually. Okay, the angio show that the obliteration of the left main. Okay, so once again I do the dual injection. Dual injection show that they did it right, and then we don't have the video here. So you see, did the right coronary artery and give the cholesterol to the left side, and they did the circumflex receive the cholesterol from the right side. And they did the LED also receive the blood from the BDA up to here. So no left main with the guiding from the left side. Okay. So according to the protocol to do the CTO, so I think they did the anti-grade, the approach, no choice already. So we go from the retrograde. So based on the very early protocol that we have to go from the retrograde and antegrade, no landing zone for the guiding catheter, so we don't use this one. We just use the retrograde. So of course we cannot apply CAR or reverse CAR in this situation because the antegrade guiding catheter is not working. We just use the retrograde technique, and we try to go through the septal first, and then we go back from the back door and go to the left main. And at first we use the microcatheter, and we use the XTR in order to go to search for the interventional cholesterol to go up to the mid LED and then go to the left main. And during the intervention, the patient feel uncomfortable, feel not painful, not very painful, but the patient feels shortness of breath, and the patient feel very tired. Look at the EKG, and EKG is normal. But the blood pressure down from 120 to 90. So what do you think? I would like to stop here for a while and ask who is specialist in the retrograde intervention. We guiding the AL 0.75, and during searching for the interventional cholesterol to the left, the patient blood pressure down from 120 to 90. So Shozo, what do you think in this situation?
Flow is okay.
Yeah.
Flow in the right is all right.
Yes,
Just
flow
blood
on
pressure
the
drop.
right is okay. But the blood pressure is down like this, okay? It's going down.
Oh.
The guiding again? Yes, the guiding sitting on the valve. Yes, all right, excellent. Okay, so at first I didn't realize that, because I look at the flow on the right side, because I think about the thrombus formation inside the guiding, but the EKG is okay. EKG is normal. That small test is the RCA is still flow, limit 3 flow. So, okay, so we saw this. Look at this. So I discovered, okay, the AL1 is very strong backup, but we have to be very careful because sitting on the valve cannot open enough to get the blood out from the LV to the aorta. So we have to remove it because we know that that's a strong guiding catheter, but I have to exchange to another guiding catheter, JR guiding catheter. Okay, so look at again, only the limit 3 flow, RCA, but the guiding had to be replaced. Okay, so that's the first issue. Okay, so and then we have to exchange change to another guiding catheter, the JR guiding catheter, and again I use the XCR in order to serve for the interventional cholesterol to the mid LED. And after cross to the left side, I change to the Gaia 1 and then Gaia 2nd in order to poke the left main. Okay, so you can see here is the very long way from the RCA. Now is the JR 6 friend getting catheter, and it have to be stay away from the valve and just around the aortic root in order to avoid that the guiding sitting on the aortic valve again in order to make the patient feel comfortable and still lie flat for us in order to do the intervention. So this is the XTR, and then we actually now with the guiding Gaia 2nd. And after around 10 minutes, in order to poke very sweet, apply strong force in order to cross into the aorta. So now it's go, but the guiding, the left guiding catheter is still there, but we cannot, of course, we cannot go into the lumen of the guiding catheter on the left side. So how to capture it? Some operator, they will stop here and then they use the snare and capture this at this, but I did quite a little bit different. I keep pushing the retrograde wire to the subclavian artery. Yeah, so the externalization also a problem because they keep pushing. Look again, see? So the guiding is just here for fun, not function. But I don't want to capture the wire here because it can cause it makes the wire like a rupture or something like that. So I keep pushing and go into the left or the right side, both sides. But I want to wire to the right side because guiding on the right side already. So I just thinking about how to externalization that. Okay, so this is the JL on the left side, and RT330 will externalize to the radial sheet like this. Okay, keep pushing and then easy capture here because here narrower. So even you use the two wires to stick together and driven the retrograde wire into the guiding the left guiding catheter. So I capture here. I didn't capture at the aortic root because there's the wire keep floating and take time. And when we keep that, if we pull down, we can call the dissection of the left main also, because the microcatheter had to be outside the left main first. Okay, and then now we already capture at the subclavian artery, and then now we just do the intervention at usual manner. Okay, so use the 2O balloon, and then we do the balloon inflation, and then we do the 3.5 by 18 millimeter DES in order to from the left main for the left main trunk, and then we do the final. But unfortunately, we don't have at that time we don't have the IVAT catheters, so we don't check what is the mechanism underlying this situation, because the patient had the symptom for 1 year, but the procedure, the surgery already lasted for 10 years, almost 10 years already. So I don't know what is the mechanism of that, but that is the limitation of this case. So okay, finally we just add the normalization to the radial artery, and then just put the balloon in and do the stenting, and then post dilatation. So now the left coronary artery to get the itself blood from the antegrade to the distal. So this is now it appears again, and the valve still functioning like this. And this is my conclusion. And chest opening after mechanical valve replacement for CABG is so complicated operation, but percutaneous intervention is an alternative method. Once the surgeon don't want to do the bypass or even the mid-cap, we have to try to open it by PCI. Through and through controlled retrograde technique is the only one for obliteration of left main coronary artery. I also have some cases like this. Not really only the one case, but after that we have also some cases. The patient replaced the aortic root with the Bentham procedure or something like that, so the left main disappeared. And then we have to use the Conquest 20. At that time we still have the Conquest 20 in order to poke to the aortic. So very strong, apply very strong force in order to poke into the left main, into the aorta. So it's not very rare, but sometimes we have to do the through and through technique like this in order to conquer this kind of obstacle in order to finish the procedure. So thank you very much for your attention.
Excellent job, Hung. Any comments or anyone? Kirk?
I think thank you for the lecture from Dr. Hung. I think with this lecture I learned two lessons. The first of all is about the guiding catheter sit on the valve, the mechanical valve, so the blood pressure go down. And the second thing, I think most of aorto-ostial lesion like that, if we don't have the collateral, we cannot do anything. And the third case, I think in this case the mid-cap can do because it did not like open the chest like before, and they can do easier and easier than we do a long case with that CTO like that. But not at all. Dr. Hung finished the case very successfully, and thank you.
Actually, I received the patient from the surgeon, so they refused the procedure already because they see that in order to dissect the chest, in order to get into the LED and get the graft in is not easy because the patient already had undergone a very big procedure by replaced by 2 valves. So that's the reason why we have to do something that. So sometimes we have to do, like nowadays we have a lot of TEVA procedure and left man maybe disappear like that. So I think one day we have to receive the patient like that in order to do the procedure. Rosli?
I think the only thing that I can probably want to add is that you got to be careful because sometimes there is no left stem. So my colleagues who does CT scan, I remember this last 1 year, he showed me 2 cases when he did CT, and there was actually no left stem. So it was actually coming and supplied by the left. So I think if you're not sure, a CT is also very important for you to define. Otherwise, you're going to try, but it's actually not really there because patient doesn't have any left main. So that's the only thing that I think to remind ourselves. Yes, sir.
Just one comment. I think concerned about the guiding over the right side. I think it's just not commonly see in the aortic valve replacement case, but it's more common in the native aortic valve. So usually when you're doing CTO, you have bilateral injections. You have 2 catheters, right? The warning sign usually is for both tracing, you will see the vascularization, not just the right side. I mean, not just the one from the AL1 engaging the outside, which is in difference to those only the damping of the pressure from the AL guide towards the outside ostial, right? Because the quadrilateral guiding will also give you hints. Both pressure is going low, then something is happening. It's not just because of the deep engagement of the guiding. So you just take out the AL1 guide and then the pressure will relieve, and then this is the pains to help you stop the patient.
Thank you very much. But the mechanical valve is easy to get trouble like that. With the the original one is not. It's not like clear like a mechanical one. So when I replace to the JL, I make like a U-turn. The U-turn to the aortic root, not directly in the central. So we escape from that, and the patient blood pressure go up again. That's just the tip and trick in this case. So I think if we don't have any comments, so I would like to introduce the next speaker. Dr. Rosli will give us the presentation entitled Essential in Management of Heavily Calcified Coronary Lesion. Dr. Rosli, please.
Thank you very much for the kind invitation. Shozo, we have something on us, so I'll just touch a bit about the calcium modification afterwards. Can I move this? Yeah. Okay, I just want to start with the case. Essentially, this is a lady that was done, and you can see about a pre-balloon dilatation, there was a waist, and upon using a 2.5 non-compliant balloon at 26 atmospheres, it was full. So he decided to use a 3.0 non-compliant balloon. At 30 atmospheres, there was still a wasting, and he thought at that point in time, I will put in a stent and it will be solved. Obviously, it did not. So the first thing one must always remember is that when you have an underdilatable lesion, do not implant the stent. You've got to pre-treat it. You must make it fully well dilated before you implant the stent. Obviously, it's not surprising the lady came back with stent thrombosis a week later, and when we analyzed that, she came to our side, and you can see that there's, at a point where the tip is, the stent was not expanded. So that is the first essential I want to remind you, is that always respect calcified lesion, especially if the calcified lesion is severe. And you know that the challenge of treating calcified lesions, the more severe it is, the delivery devices, the immediate complication, you tend to use more devices to get better results, time and cost. And the results definitely will not be the same as in a lesion that is not calcified. And the stent can be underexpanded if you implant a stent, and there you have the risk of stent thrombosis, in-stent restenosis, and increased TLR. And the calcium severity is that you tend to, when you have mild, moderate, and severe, it's clear that when you have the more severe calcification you have, the higher the event rates. As you can see, death, cardiac death, MI, TLR, and also the total MACE is much higher in calcified lesion. So the question is how best to assess a calcified lesion. It is well known that angiographic assessment tends to underestimate calcium. So in this study, that's well often quoted is that calcification is seen in about 38% of patients during angiogram. But when you do intravascular imaging, and in this case, an intravascular ultrasound was used, you can see much more. 3 out of 4 patients by IVUS they can actually detect calcification. So this is something that you need to understand. There are various types of calcification. I'm just showing you 5. There's actually another differentiation of, or rather different calcified nodule. Deep calcium, what it looks like in intravascular ultrasound and OCT, superficial, concentric, eccentric, and calcium nodule. And we now know that there is a non-eruptive and eruptive calcium nodule. There are certainly differences between OCT and IVUS. It depends on what you have. I think apparently in Vietnam, I hear that there's no OCTs. But you really have to know the advantages and disadvantages of one or the other. But in general, if you are to use for normal day-to-day cases, it depends on how comfortable you are, how confident you are in terms of analyzing the the features, morphology, and so on, and using it. And what Professor Tan Hui Chim mentioned today is that what is important is not just assessing and analyzing it and interpreting it. What do you do with the results is very important. Okay, what you find and you act upon it. From a calcium nodule, from the point calcium nodule, one of the main aims, one of the main, thing that you want to look for is actually the arc of calcification. One arc or one quadrant, which is 90 degrees and so on and so forth. And we know that the higher the number of arc which is involved, then the stent expansion will be worse. So the more concentric the lesion, the more calcified lesion, the more poorer in terms of stent expansion. And you find that as the lesion goes up more, then the use of atherectomy increases over time. Then there are ways that you can actually score this and then decide on how you want to act upon it. So this is what we call it as a calcium scoring system, an OCT base looking at the angle or quadrant, the thickness and the length, and then you come to a scoring. Intravascular ultrasound also gives the same way, but the advantage of intravascular ultrasound that is incorporates the calcium nodule into it, and then you can even score. Now, the calcium score actually helps us to predict stent expansion and therefore how you want to go on and treat this patient. A calcium score of 2 and more would necessitate more than just balloon angioplasty. It tends to calcium modification by debulking, and this is where you know that if you don't do well in vessel preparation, the risk of stent expansion being poor is much higher. So that's the second essential. The third essential is that how do you want to treat a calcified lesion, whether calcium modification or calcium removal or debulking. This is a slide that was given to me by Hui Chim, and he said that intravascular imaging, I feel, and I think this is something that we should inculcate, is that it is essential in terms of how we manage calcified lesions. I know that not many centers have intravascular imaging. Not many centers can actually do it because of cost, but at least we try to understand that yes, it is essential, and we try to work towards it. And it is very clear that from previous publication and so on, you access it in terms of pre-intervention assessment, and when you vessel treat before you put in a stent, you then assess once again to see in this particular case where the calcium has got fractures, and then subsequently to assess post results. Now this is an algorithm, so strategy will be, I think if you have based by an algorithm, it will help you. So this is a fairly practical thing, looking at balloon crossability, especially when you have calcified lesions, severe stenosis, you think that the intravascular ultrasound or rather intravascular imaging device cannot go through. So if let's say the balloon is crossed, then you can pre-dilate that. Once after pre-dilatation, it allows the crossability of the device, imaging device, then you go and do that. From there, you have this, what we call that, features to suggest poor outcome or good outcome. So if let's say the outcome is fairly good, the features are not very high, means the score is low, then you try to use a non-compliant balloon, and in this case, or even a specialty balloon, and you have to aim for optimal balloon expansion. once you have attained an optimal balloon expansion, the vessel is dilated fully well, then you put in a stent. Now, if you use specialty balloon or non-compliant balloon, it doesn't expand well, then in this case, you have to use IVL catheter. And once you get good results, then you use a stent and optimize the stent. On the other hand, if you cannot cross with the balloon, which is on the right side, then you use a microcatheter. If you can pass a microcatheter down, then you atherectomy. And you then, following atherectomy, once again, get an optimal balloon expansion. And if you say yes, then stent expansion. If no, then once again, you think about IVL. And in the beginning, if let's say you cannot cross microcatheter, then you go direct wiring, and now the wires are much better. You can directly wire, and then again go on through the same algorithm. What is important after stent expansion is to see the stent, the results, and then treat whatever which is not normal appropriately. So that's a fairly simple, straightforward algorithm for approaching calcified lesions. I once again want to stress to you the balloon expansion, balloon to artery ratio at least 1:1. If you use imaging, then you might want to take 1.1:1. And this has to be with a non-compliant balloon and high pressure inflation. So I always take it. If you even you have it, you have got 1:1. Like in the first case, he did it with a 2.5 balloon, whereas you know that the vessel is 3.0 and he should have used a 3.0 first. So always do that. Even it is routine for me that if I have to, I put an IVL, I still tend to use an optimal balloon expansion following the procedure. Essential number 4, having the right tools. I think this is very important. These are some of the things that I use for treating calcified lesions. I know they've got calcium modification, which is with the specialty balloons. Calcium removal or debulking is with the atherectomy devices. Now, the non-compliant balloons, I just want to share with you that there are different type of balloons. I think you now have balloons that can go to 20, 25, 30 atmospheres with a non-compliant balloon. The only thing is that you got to remember 2 things. If you go after 20 atmospheres, you got to go slow. 20, 22, 24. Because if you go too fast, the balloon bursts. Okay, so go slow after 20 atmospheres, and it can go much higher. Now, the other problem is that when it goes high pressure, it tends to grip. It expands outside, it expands inside, it grips the wire. So when you go very high pressure, make sure you got to be very careful when you pull a balloon out, because otherwise you lose wire position. So that's the only thing. And of course, you know that once after the first use, if you want to reuse again, you need to re-wrap the balloon if you want to save costs. There are 3 types of scoring balloon that we currently have. We have the Scoreflex Neo NC30, which is a new balloon. 2 elements plus the wire. It has got 3 elements scoring. This one can go to 26 atmospheres, and I don't know why. The technology is now good. I don't know what they do to improve. It doesn't grip onto the wire, so no problems. You can always take it out. Even with the NSC Aperta, which is NSC Alpha, this can go very high pressure. Cutting balloon, usually I don't use more than 20 atmospheres, but I see my Japanese colleagues go until 30. Now I'm braver to go to 30. But remember, if the vessel is 3.0, don't use 3.0. Use a 2.75 or 2.5. Otherwise, you can have perforation. Now, the OP and NC, obviously, once again, you got to go careful. Even though this the nominal pressure, I think the rated burst 35, you can go 45. I've seen people going more than that. But again, you got to be very careful. The higher you go, the more it grips onto the wire, right? The atherectomy system, I'm not going to touch much, but perhaps it is going to be mentioned afterwards. But this is something I learned, is that when you want to go, it's very difficult to go through. You can go very high RPM, 190 to 200. And what it does is just create a path. So the bulking amount of area which is debulks is very small according to what the size of the rotablator is, the burr size. Once you have done that, you go slow speed, and this gives you a better debulking area. So fast and then slow. But obviously, the faster you go, the higher the risk. OAS, we've had it for a couple of years. I think it is quite useful because one size so-called fits all. And this is an example of a person with severe calcification, ostial stenosis. And I find that with the OAS, the risk of the slow flow risk is much less. The risk of bradycardia is less. This patient actually had a slow bradycardia, but it can easily be treated. And I don't put a pacemaker, I mean, even in a large dominant right coronary artery. And once again, that was done at high speed, low speed, and high speed. We just lifted up the catheter to try to ablate the ostium much better. And that's the results after. Shockwave is something that has also made life easier, and it's intervention is like it because it's like a balloon. The only thing is that it is fixed to a machine outside. This is an old device that can give 80 pulses. The new ones can give 120, and you have the ones coming out from China trying to compete in the space. So this is an example of a patient, a left main stem that was significantly stenosed, and IVUS showed only about 4 mm squared. This we just put in is quite easy because not very severe, inflated to about 4 atmospheres, give pulses, and you can see over time the vessel actually gave way. So since it's very expensive, we try to finish off all the pulses for this patient. And that's where you can see the cracks in the calcium. And that's after treatment with stent, and that was the results after. So I just briefly say a bit about the comparison. Plaque ablation is not seen with IVL, rather it's seen for rota and also OS. And then the effect on deep calcification perhaps is a bit more for IVL than compared to the others. I want to just touch briefly with something which is new, and we should be watching out for this space, the Hertz contact intravascular lithotripsy. And this is very interesting because when you have two surfaces which is, meet up together, the force, the stress will increase, and therefore you can actually have a high stress area. So for example, if you knock a windscreen with a hammer, it's very difficult to knock. But when you have like a hammer with a small surface area, when you crack it, it's easy to crack. So with this is what it looks like, microspheres on the balloon catheter, small microspheres. When you have at 5 atmospheres, there's nothing there, it's just inflation of the balloon. It is equivalent to about 60 atmospheres, and at 12 is equivalent to about 80 atmospheres. And it doesn't do much with the soft tissue. So this is something that's been shown to be useful for nodular, eccentric, and concentric. And the first in men study shows that the fracture of the calcium is quite deep, and the expansion of the stent was about a bit more than 90%, which is very difficult to find. So last but not least is remember to assess results post-PCI. And these are the defined criteria. You want to expand the stent very well. Don't leave large plaque burden greater than 50% at the edges. Aim for complete stent position. Obviously look for edge dissection and treat significant tissue prolapse. Now, to summarize, ladies and gentlemen, you need to respect all calcified lesions, especially the heavily calcified lesions. Assess the severity of calcified lesions, very important for you to consider imaging in this case. Follow treatment algorithm. It's simple and you can remember. Have the right tools ready. Assess the results post-PCI well. And if you need to, refer out if it is in the best interest for your patients. Thank you very much.
Yes, thank you very much for the excellent presentation. Actually, I would, please come here. I think I want to get some comment from the panelists on the right side, Dr. Alan Chan and Dr. Marida about this presentation.
Very comprehensive and nice talks. So concerned about the atherectomy, I think recently there's some update clinical trial, especially on talking about calcified lesions, talking about the comparing the OAS versus the traditional balloon. Surprisingly, the result is negative. So so I just want, of course, we already try to fit in different devices in a different clinical scenario, right? So what do you think? I think the future direction. So any comments and.
Okay, I think it all depends also on how comfortable you are using with one device or the other. I feel that number one, the atherectomy will still remain. Sometimes it's so diffuse, long, severe calcification, you can't put in any devices too. You have to do atherectomy. And for the severe calcified, it's not uncommon for you to combine two devices. For example, atherectomy. I've had two patients, I remember, atherectomy and OS, and the other way around. Of course, it's common with atherectomy and then with IVL. So it's going to be there, but in the end, I'm putting a bit of hopes in the lithics balloon because it sounds interesting. It's a bit more difficult to go in because of the microspheres, so it's not as trackable. But the first in man shows that it's quite easy to use, and you don't have anything there. So I believe it works. Then you have an added armamentarium, added device that will help you to treat calcified lesions.
Can I have a question? Can I have a question?
Yes, Dr. Nam.
Yeah.
Yeah.
Thank you very much for your presentation. I have a question that I agree with you. We need to prepare the calcified lesion very well. But if we do it very aggressive, we are afraid about perforation. So what size on angiogram and on IVUS tell us should we do? What size of an NC balloon would we choose? Or you choose or routinely 1:1 ratio? Yeah.
Firstly, I think, as I said, imaging does help because it tells you how severe calcification, the arc calcification, whether it's eruptive, nodule, or otherwise. And that will help you in terms of your devices that you want to use. So, as I said, if let's say it is severe calcification, then atherectomy will be useful, and after that, post-dilatation. I still feel that once you have done a proper preparation, especially when you use atherectomy, it is now safer for you than to use balloon. And for balloon, I believe that you should still use 1:1 balloon, and you can go high pressure. Of course, the risk of perforation is a bit higher, but that's something that you got to to consider. If you are concerned, you can downgrade by a quarter size, and then you go high pressure because at 26 or so, then it's going to be a quarter size more. So at least a quarter size smaller if you're concerned.
So is there any symptom or signs on the IVUS predict the perforation after balloon?
Yeah, one of the things, of course, before you want to put in the stent, you want to see these cracks. So as long as you can see fractures, you'll be good. The calcium nodule can be difficult. There are two types of calcium nodule. One is eruptive. The eruptive is easier to treat, but the issue with eruptive is that long-term outcome in terms of TLR and outcome at 1 year is higher. On the other hand, non-eruptive, where you can see the cap, it's very more difficult to expand. So this is where, if let's say it's really you haven't really treated the calcium nodule, this is where you need to pick up things like an IVL to try to break it up. It is not easy to treat. You are probably going to use more pulses than usual, but you need to try to do as much as you can. The expansion may not be as good, but the outcome is less in terms than compared to eruptive nodule. In the end, in total, sometimes you cannot do more. What you need to do in the end is make sure that the expansion, the stent expansion is good. As we said, it should be more than, at least 5.0 for a non-left stem and more than 90% from the distal area. So try as much as you can. And of course, vessel provision, and then that, try to get good results.
Thank you very much.
Dr. Rosli, I have a short question for you because according to the early days, they did research about rotor search. You know that the rotor search make the guideline. So they accept that the residual standard is around 30%. Sometimes it's 10%, okay, but a little bit more. Some cases they still acceptable. But nowadays, of course, we don't accept that. So in some situations, you still accept that the residual standard or just have to go up more in order to get under 10%. What do you think?
I think the data now suggests that we need to go as much as you can and get better results. Those were the days, but the current data now again suggests that stent expansion is if you want to put in stent, it has to be a certain size and so on, because otherwise the risk of coming back is higher and therefore the treatment is worse. We just need to try, and quite a number of cases that if you see imaging, it's clear. If you don't use imaging versus angiogram alone, you do not get as good expansion as when you use imaging. So in very severe calcified lesion, I think you should try and do the extra. In mild to moderate, perhaps you can still get away, but for severely calcified lesion, you just have to do more.
So this topic quite very hot. So I think, but we still have the question. But now we have to move on to the next speaker. I would like to invite Dr. Ho Anh Binh will give us the presentation entitled "Challenge in Left-Main Coronary Artery Intervention." Dr. Ho Anh Binh, please.
Thank you very much for inviting me to the conference. My topic is about the challenge in left-main coronary artery intervention. As you know that at the first left-main intervention in 1979, since then a lot of interventionists want to do the left-main intervention. This has become a very interesting challenge. And since then a lot of study and also the consensus or guidelines to have to show the benefits of the left-main intervention. But the most important thing is that we need to have the heart team approach. If the lesions favor for the CAP or the favor for the PCI, we have to choose. This is the algorithm to help us to do the intervention, need to do or not. And especially we have to have the IVUS or FFR to do the left-main intervention. It's very important. And we need to do to use this emergence in doing the left-main intervention. We also know about the anatomy review, about the anatomy of the left main, the lesions in ostium or the middle or the distal, because we can choose the strategy or plan to do the left main intervention. And a lot of people get high risk if they had the stent thrombosis, especially if we have the malappositions of the stents or the protrusion tumors stent into the aorta or the medial tear, etc. So we had to prevent it. Optimal use of IVUS is very important, and it also helps us to reduce the mortality after doing the PCI. And sometimes we can avoid the unnecessary PCI or CAP intervention for the patient. And the roles of IVUS and the roles of FFR very clear, even before the PCI or after PCI. One of the things, it's easy to miss the left main injury because when we do the angiogram, the catheter deeply engaged to the left main, and the stenosis lesion may be easily overlooked. And sometimes we do not use enough angiographic views, and some indirect signs suggest the possibility of left main lesion include the loss of contract reflux and pressure damping. Some point that we need to pay attention to. Further on, you have to choose the catheter that minimizes spasm, and the side-hole catheter is no longer recommended because they lose the damping pressure. We can use the outer free floating wine techniques to prevent it, especially when we pushing the catheter deep into the left main to get good backup, or when we pulling the post-dilatation balloon gel way back to the catheter. And we should also keep an eye on the catheter tip and pull the catheter out of the left main ostium. When pulling the balloon or pulling the gel wipe back into the catheter lumen when there is no floating wire. And we also select the catheter with appropriate diameter. Normally we use the 7 French catheter, but sometimes we can use 6 French in the simple case. Other thing is that we should have the very good lesion preparation. We can use the cutting balloon or DCA because the muscle layer of fibrous tissue of left main are very thick, especially in the osteo. So they limit stand expansion, and the possibility of recoil and restenosis is higher, even higher in the lesion accompanied by the calcification that we have just listened. And the coronary artery calcification is a disaster, especially in the left main intervention. It's very easily to get the thrombosis immediately. And we also have to select stand, good stand, with the larger is better, because sometimes with the mismatch between the left mains and the LAD and circumflex. Some stand we usually choose during the left main intervention. Other thing that we pay attention to the aorto-ostial landing zone, and we normally choose this view to do the intervention for the ostium left main. Sometimes we can use the floating IVUS to do the exact implant stand in the ostium or in the ostium of the LID. We optimize the POT and IVUS OCT to check after doing the PCI, using two criteria, music and criteria and IVO criteria for evaluation. And also we have to do the post after ostial left main stenting to prevent the wrong ways when we insert rewise or doing stand. And this is the IVUS criteria for optimal stand deployment. We have to finish on this. And about the depth strategy, if the patient can continue depth without major bleeding event, we need to prolong depth over 12 months, and it had a better outcome. And this is some research that help us to do this. The MACE is reduced significantly after we using the depth over 12 months. And the last thing is that we can do the angiogram or CT scan after left main PCI before some recommendation from ESC. Coronary angiogram after 2 to 6 months after left main PCI. But today it no longer makes the recommendation. So we only need to do the angiogram after if the patient had the symptom. And also we should pay attention to the left main distal bifurcation lesion. We choose the form bifurcations or true bifurcation. This is rather complex, and the doctor need to have at least two techniques of two stand techniques to do, and also we have to use the IVUS OCT or apparatus for guiding. Prepare the lesion well under IVUS guidance before stand replacements at left main bifurcation to reduce the occurrence of restenosis. This is my case study. 62 years old male with non-STEMI. He has the hypertension control, hyperlipidemia uncontrolled. He presents with the recurrent angina class 3, and she had the period CID stand at proximal mid-LAD and proximal L6 in 2022. And we use on-cut 20 July, we reviewed the lesions in the left vein. You can see in this view, we nearly normal lesion, but in the right side we see 99% of stenosis at the left vein. It's very severe. And unlucky, the patient had also the CTO on the right side, but the patient refused to do the bypass surgery. So we choose because it's lucky that it seems that in the ostium of the circumflex there are no lesions, so we choose the crossover left vein LAD. After we use balloon, and then we check by IVUS, and we see the very tiny lesions in the left vein. And after that, we do the implant the stent, and we check TB views to see the very clearly the ostium of the left vein. And at that we do the IVUS, and then we see that the patient rather good the result. 1 week later, we do the CTO at the right side, and we use the Fuder ST and Cochlear to do that. And we also use the extension guide to help to do their long lesion. And we check IVUS. We guide extension to support the stand, and 2 stand up 3.5, 38, 2 stand. And the result rather good. Oh, sorry. The K2, 79 years old male with chest pain. He has the hypertension and hyperlipidemia. We do the angiogram, and we see a lot of calcified in left main, and the lesions are rather long. We decide to do the 2 stand techniques at bifurcation, and we also use the IVUS to do. After you check the IVUS in the LIDs, and then change to the LCX to do the intervention. Because the lesions are very tight and calcified, so we decided to do the cutting balloon to prepare the lesion. And after that, we use the non-compliant balloon 3.5 to have the better preparation. And we check the angio again. And we do the IVUS. We see the calcium fracture here. And then we stand the left mid LD 3.5, 38, cross over the circumflex. And this is the result after we do the POT and kissing the LID and circumflex increase. And we do the inverse pull back from LID to left main. The results are rather good. And it's not good, so we do the POT again and check again with the bigger balloon. And this is the final result. And technical basis, left main coronary artery PCI is always a big challenge for interventionists, despite their extensive experience. Careful assessment of the lesions and specific planning will help the intervention become clearer. Mastering the principle as well as the note tip in the manipulations of each instrument will help us avoid falling into difficult situations that are difficult to resolve. Thank you very much for your listening.
Yeah, thank you very much for the excellent presentation. I think in this room we are the interventionalists and we involved in the PCI for left man. So I had a short question for you that if you have the true bifurcation, left man bifurcation, so what technique do you prefer? For example, two-stand technique. True bifurcation and two-stand technique. So, which technique do you prefer? Which technique do you think that it is the most effective?
For me, I usually do the mini cross technique more of the case, but depends. Sometimes we choose this stand, for example, but most of the case I choose the mini cross.
According to the guide, Dr. Takasi, you have any comment?
Yeah, so just one question, not for stenting. When you stent of the left main, especially for the ostium left main, you recommended RAO cranial view, right?
Yeah.
I think left RAO cranial is better for stenting. Yeah, for the left main stenting. So usually I prefer left RAO cranial.
Yeah.
How do you think?
For me, sometimes it depends on patient also. So until we choose the view that we see the very clear imaging, I will choose. But most of the case, I choose the TMI view. Most of the case, it's for me.
Guidelines give us that they recommended that we have to use the decay crush, but in clinical practice, I think a lot of doctors they perform the mini crush. So what is the difference between the guideline and the clinical practice? Because the procedure is laborious for you, or what else?
I don't know, because I think I would go for double kissing crush because that's where the data is. You just need to have about 2 or 3 steps more. But I think because of all the advantage of decay crush, you need the crossing over is much better. You get a much better position and carina. That I tend to use really a double kissing crush, mini double kissing crush. I don't go for nano. I think nano is a bit too challenging for me because you might miss the ostium. But I on a personal basis, I'm moving away towards 2-stand strategy to single stand, really, because it makes things easier. Plus the fact that there's only one stand structure. I mean, one stand rather than 2 stands. So in long term, I believe that it's probably better to try and think whether you can do just provisional. I think we'd like to say thank you very much for the great work you do in Hui. I'd like to invite Dr. Shozo. We will definitely give you a bit time, Dr. Shozo, and you're going to discuss calcium modification techniques for CTO PCI.
Thank you, Dr. Rosli. So, Dr. Rosli also already talk about the calcium lesion and the problem of the calcified lesion. So today I talk about the calcium modification, even especially for CTO and also complex PCI cases. These are the problem of the severe calcified lesions. Of course, it is a barrier for wire crossing, also device crossing, microcatheter balloon, and also we sometimes face incomplete stent dilation. It's expansion. It's also a problem. And also another problem is a high risk of complication, perforation, dissection, device stuck, anything. And finally, not at that time of the PCI, but later phase, we face the poor clinical outcome. There are so many studies about the calcified lesion or calcified node, but because of the time limitation, I don't talk so much about that. So I will talk first of all, talking about CTO. So it is a barrier for wire crossing or device crossing. So we sometimes use balloon anchoring technique, as you know, and also, of course, guide extension catheter is one option. I will show one case of very severe calcified CTO lesion. This is our area CTO lesion, and we can see the good collateral from left coronary. And so in the mid part of the CTO, we see the very severe calcified. And also, fortunately, I use the Corsair and XTAA, and a little bit advanced, but even antegrade wire escalation, Gladius, Gaia X2, and even Conquest Plot 12, but it cannot cross. And sometimes we face very hard wire was dropped in the calcified region. So I retrieved and changed the Gaia X4. Fortunately, Gaia X4 crossed the region, but in this point, Corsair still not. And too much rotation Corsair, we faced the Corsair was trapped in the lesion. And at that time, wire was bited by the Corsair microcatheter. So even using balloon anchor technique, I couldn't advance the microcatheter. And then biting Corsair should be a little bit with the wire. So that, unfortunately, once again. But in this kind of situation, don't use Corsair again. So change it to the normal workhorse microcatheter like fine cross, or in this time, Japan, we can use the Jizai, almost nearly microcatheter as a fine cross. So that XTA was crossed, fortunately, and also open up with 1.0, not crossed, and 0.75, not a little bit advanced, and then advanced to 1.75. But even these kind of small balloons couldn't cross the region. What is the next option? So guide extension, but if we use guide extension, we should retrieve the balloon anchor. And also change guiding from 8 French again, and so once again make a system, or try to cross the rotor wire directly. It is the one option. So advancing microcatheter as far as possible, and then change rotor wire floppy. These days, Boston's rotor wire drive is a very crossable wire. So fortunately, rotor wire drive floppy was closed, and also in this situation, we can do the small bar rotor ablation. And then after crossing the lesion, microcatheter was passed. So, and check the distal part and check the IVAS. We see still very severe calcified like this. And then, like this kind of calcified lesion, I use the open up with the non-compliant balloon, as Rosli mentioned, very high pressure. But unfortunately, a high pressure balloon makes like this kind of balloon rupture. And then after that, I checked IVAS, but unfortunately, even like this, I could not pass yet. So that the next option is bar size up. And I used the 1.75 millimeter burr, and it was closed. And then we can advance a cutting balloon like this. And this is a 2.5 cutting balloon. And after dilation, we see maybe we can see the calcified lesion around here. So calcium was nicely cracked. Now we can see that three direction. We see the very nicely cracked with the cutting balloon like this. So then they deploy the drug editing stent, and so final result is very acceptable. Like this case. So of course, calcified lesion in the CTO is a very, very difficult problem. So that balloon anchoring, guide extension, and also so last option is a rotawire direct close. And another topic about the calcified lesion in CTO. This is a relatively senior age female, and she received many times of PCI for the proximal RCA. And so many, 3 times of the stent was deployed at the proximal lesion. And so she moved to our lesion city, and also she feels still chest pain, so that we check the angiography. Unfortunately, proximal stent was occluded at the ostium like this. So already stented many stents. We can see the stent very clearly because of three times of the stent. So what we can do? Of course, so any kind of wires or microcatheter we can use, so that lesion was closed, not so difficult, and even using balloon anchoring technique, so we can advance the balloon and also microcatheter, and then you even using cutting balloon. This is 3.25 cutting balloon, but still not expanded well like this. Why not so expanded? Because in calcified lesion, the previous doctor put in so many stents like this, so it's a problem. So that, do you put stent? No, only DCB I did it in this timing, and so I was showed like this in one point. Still, calcified lesion and also the expanded stent we can see. So in this timing, so we finish the procedure. Sorry. Still not working. So I'm sorry, I can. It doesn't move. But so of course, so TIMI3 flow was obtained, but so not so expanded. So that we planned second session with rotablator for stent ablation. Not moving. I don't know why. So I use the 8 French guiding and also using the rotablator. This is our CT image. So we can see the very severe calcified, and also stent is not expanded in the calcium like this. So okay. Yes, I performed the 2.20 rotablator with very careful manipulation like this, and also up to 2 to 5 rotablator like this. And then use a high pressure balloon, and also DCB was deployed, so the balloon expansion was very nice. And final OCT also showed after that high pressure balloon dilation, so we didn't find the not expanded lesion. So this I'm sorry, but so final result is very nice, and also this is also the 9 months later. So I did the follow-up angio. So fortunately, the result is very nice. I'm so sorry, it doesn't move. So there are some reports about the stent ablation, but stent ablation, of course, might be one option in situations, but safety and efficacy, and also appropriate rotation speed, and also optimal artery ratio is still unclear. And also, of course, we should be careful of the complications. And also, the most important thing is not putting stent for enough lesion, without enough lesion preparation, or not expanded lesion. It is a very bad outcomes. So incomplete stent dilation makes very poor outcome. So that appropriate calcium modification is mandatory. And also stent ablation is a final option. It is a solved problem of the calcified lesion. So another topic is complications. So we can see the severe calcified lesion at the circumflex ostium. And for this case, I performed the rotablator with 1.75 millimeter burr, but unfortunately, rotablator was stuck here there. So soon I insert the additional guiding catheter. Already we can see the double guiding. So it is a kind of ping-pong technique. And so fortunately, so very slippery wire, Sion black passed beside the stuck bar. And so using with the balloon dilation, fortunately successfully retrieved. But we sometimes face this kind of complication in the severe calcified lesion or CTO or complex situation. And another problem is a perforation. So bending lesion, and also if there is a very severe calcium at that time, it is a very high risk of the coronary perforation. We should remind. And so there are some, so that we need any kind of lesion modification. So of course, high pressure balloon and scoring or cutting balloon is sometimes effective. And I mentioned about the rotablator. But another option is IVL. Today is another topic. Yes. So IVL is of course very useful. Even in Vietnam, it is still yeah. But so of course the IVL is very easy to manipulate. Even young doctor can do easily. And also it is a very big advantage. Avoid slow flow in diffuse lesion, long diffuse lesion. Sometimes we do the rotablator. At that time, slow flow we face. But disadvantage is poor deliverability and also very expensive. And also availability in some countries. It's also a problem. I will show one case of IVL. We can see that subtotal occlusion of the proximal LAD and the severe calcified lesion. And then XTR and Caravel microcatheter was passed, and I open up LAD and diagonal branch, both small balloon, and then after high pressure balloon, but even high pressure, but balloon is not expanded well like this. Long and bend lesion, if I perform the rotablator, it might be a very high risk of perforation. So that I use shockwave like this. This is a 2.5 shockwave IVL. And so then we can use IVL for the diagonal branch. Even so, crossing two wires, it is okay. If we do the rotablator, at that time, we should pull out another side branch wires. But fortunately, so we can do like this. And then after high pressure balloon dilatation and put stent, Yokurot stenting and post dilation. And the final result is very acceptable. So this is the last case. So do you put stent or not, like this case? So this is a left main and circumflex severe calcified lesion. I'm sorry, but it doesn't move. How to, so I cannot show. How to, I'm sorry. So it doesn't move. I'm so sorry. So also I will explain. This is a circumflex very calcified lesion, and so I cross the to cross the CTO for the circumflex. First of all, I perform the rotablator for left main to LAD, and then cross the wire with the reverse wire technique like this, and so finally I advance the wire to the circumflex, but after that, I perform the circumflex because this is a very bending lesion and very severe calcified nodule at the circumflex ostium. So that I perform 1.25 millimeter burr, only small burr, but it was enough. And then open up with the balloon. But after cutting balloon, shall we put the stent or not? Because there is a very big calcified chunk, calcium nodule at the circumflex ostium. So that in this kind of situation, DCB, drug coating balloon, should be considered. And this is the final angio. But so, it doesn't. So if we cannot get enough lesion modification or balloon expansion, at that time, we should avoid stenting. or we should consider drug-coated balloon. So there are so many lesion modification for calcified lesion, including rotablator and also RBL. And so this is the final slide. Role of the calcium modification, it is important to make support for the device cross. And also it makes better stent expansion. If we cannot get enough expansion at that time, we don't put stent there. And so improve clinical outcome and also, but still challenging even with rotablator or IVL because we should pay attention for complication, rotablator stack or perforation. Thank you for your attention.
Yeah, thank you very much for the excellent presentation. Actually, I would like to ask the right panel that any comment for Dr. Shozo because this is very interesting topic, very excellent topic. No, yes, Dr. Hong Bang.
Okay, thank you for the excellent presentation. I ask you one question. Okay, in the calcified region and special CTO calcified region, what wire you use? Wire you use in this situation? Yes.
Yes.
And the second question, in the neuro calcified, and then how to treat its neuro calcified region.
So first question. So if the lesion is very calcified in the CTO segment, at that time, normally wire selection is same as the normal CTO, but if we feel the resistance or difficulty of the wire crossing, at that time, 3P wire, it means XTA or, so for example, Gladius, Sion Black. Sion Black is not so good for the CTO, but in some situations. Or so in some countries, still using the pilot, such kind of 3P wire sometimes help to cross the lesion. And also, we should understand, so strong Gaia or Conquest Pro sometimes stuck the calcified lesion, so that at that time we should be careful with manipulation. And the second question. Yeah. So for the calcified nodule, so in the CTO lesion, if we see the calcified nodule at that time, so if we can do the rotablation something or shockwave something, it's okay. But so during the CTO, we use the many balloons, many wires. At that time, in first session, we sometimes do only get the antegrade flow. It's over. And so maybe second session, we do the rotablator as a big bar or something. Because sometimes, as you know, CTO distal part is enlarged, maybe after CTO PCI, 1 month or 2 months or later. So that it is more safe to perform such kind of lesion modification or OAS or rotablator something. So that second stage PCI should be considered for the calcified nodule, especially CTO.
I have one question. Yeah. If the lesion only have the calcification, it's okay. Sometimes we can rotablator or IVL. But with the combined lesion, first of all, the calcification, and the second is the doctors. I mean the many pen vessel, and the calcify at the top of the angle. So how you deal with it?
So it means a very strong bending. Yep.
A lot of bending, not only one bending.
So it also depends on the situation. So, but if we cannot cross the balloon or if we cannot cross the microcatheter at that time, already wire crossed at that time. Of course, small rotablator is one option. In such kind of situation, IVL cannot cross. And also OA is difficult to cross. So that only the solution is 1.25 rotablator. Yeah.
Yes, thank you very much. Because that one is a very clinical question that sometimes we have to cope with the very tortuous and calcified. But we have to keep in mind that when we cope with the vessel, what double curve like 45 and 45 degree and combined together in more than 90 degrees, so we have to be very careful with rota because it gets stuck. And then if we go smoothly and we go slowly, it's okay. But if we cannot finish that, so we have to halfway rota also okay, because we make some facilitate for the next balloon or something like that. we don't force to finish the whole thing that rotablate the whole vessel. Otherwise, you get stuck inside because the whole country I heard some burr get stuck in the vessel, but because they try to force the burr go downstream, and that's the contraindication for the ablation. So in this situation, I think very tortuous contraindication. Because you indicate that you have to halfway rota, it's okay. So don't have to, rota has a limitation. Keep in mind that. Is it correct?
Yeah, I think so.
Okay, so I think this section already run over time, so I let Dr. Rosli get the conclusion.
All right, thank you, Dr. Hung. So I think we've heard from 4 5 presenters talking about various things, but left main, distal radial, and still calcified lesions. So it is something that is coming again and again. You see that other than CTOs, calcified lesion is really the challenging case that one we need to master and understand. So I just would like to thank all the panelists for being here and for attending this complex PCI. And the next session will be in about 5 minutes. So on a personal basis, I would like to thank Hui for the kind invitation because I have to leave after this. Thank you very much.